Onc Live Insights is a video editorial program produced by Onc Live.
One of the most important issues that we should address right now is when should iron chelation therapy be instituted for a patient. And in my practice, the way I handle the situation is anytime a patient has received at least 10 transfusions accompanied by a ferritin level of over 1,000, I start talking to my patients about chelation therapy and starting to really impress upon them the critical nature of chelation for their chronic disease. And we initiate chelation therapy at ferritin of over 1,000 accompanied by 10 transfusions and follow that until the ferritin level comes down to about 500. And the way we monitor that is at least every 2 to 3 months we repeat the ferritin level. When it comes down to 500, we hold the chelation and continue the transfusions, but follow the ferritin again every 2 to 3 months until it comes back up to over 1,000 and then initiate again. So this is an episodic, sporadic sort of chelation, which I find is palatable for the patient as well, because they are not getting bombarded with having to take the oral chelator for a year on end, for example. They can take it for 3 to 6 months, hold on for 3 to 6 months, and then reinitiate. Iron chelation therapy is a kind of treatment which patients are not always very compliant about. And one of the problems that I would like to point out why this happens is because the treating hematologists are not aggressive enough in conveying to the patient the importance of this treatment. When I talk to my lower risk MDS patients who are being chronically transfused, even as we begin disease modifying drugs, I always clearly explain to them that even if you have the best response to this agent which I'm going to give you and you become transfusion independent, it is not a cure for your disease. It's not going to last forever. So you will become eventually transfusion dependent once again. So even if we use treatment that works beautifully in patients, eventually it's going to stop working and the patients will remain chronically transfused. In other words, there are just these sporadic periods in which they are transfusion dependent. Otherwise, their risk of continuously receiving all this iron is quite high. So I explained to them that the way to continue to receive transfusions safely is to continue to chelate the iron out of their body. And it is so important for the hematologists, first of all, to be themselves convinced of the importance of doing this and then convince their patients. Then the patients are going to be far more compliant. A second problem is that, of course, every drug we give to our patients is going to have some kind of side effect, even something as benign as an iron chelating agent. And XJ has been associated with some GI symptoms. It can affect the kidneys, it can affect the liver. And so we have to be aware of the side effects. We have to tell the patients. Not every patient is going to tolerate the drug as well. So we should be prepared to modify the dose of the drug to one that is palatable for the patient. But the key message that really we have to convey to our patients and to all my treating hematologists out there in the communities is that for lower risk MDS patients, the best treatment option you're going to give them are not drugs that are going to make them transfusion independent for short periods of time, but really to be able to continue to give them transfusions safely, and you can only do that by also continuing to chelate the iron out.